Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have Dr. Attaya Suvannasankha from Indiana University School of Medicine. She's Associate Professor of Medicine and leads the effort in myeloma at the institution. And I am glad to have her here today. She's really brought up the program there to new levels. And welcome, Attaya.
Thank you so much for having me today, particularly on the topic that is so important, but also very debatable still in our current myeloma world. So I'm
Yeah.
hoping that we'll have very lively conversation.
Yeah, so how I use MRD in the management of myeloma, and I would say that if I interview 10 people, they're going to have a different take on it. So that's what the good thing about this is, that there seems to be no, right now at least, set pattern and a right answer perhaps. But just to start off with, just to educate those who are uninitiated, how do you check for MRD in multiple myeloma?
So that is the first kind of topic that if you talk to 10 people, they're all probably passionate about different technologies that are being used. But ultimately, I think it's really because we are so much better with how we treat patients, so that rather than just sort of checking the blood for M protein or the light chain, we have gone way beyond that to be able to go even deeper to say, well, if the cancer cells are hiding out, we don't see them, and they're no longer making enough of abnormal protein that we can easily test in the blood, could we then evaluate inside the bone marrow and ask a question, if we look extremely hard, how many of the residual cancer cells are still available? So there are two main technologies, and I'll tell you what I use more. Two main technologies that have been around the longest. One is a flow cytometry assay, which is evaluating the remaining cancer cells based on the proteins that they uniquely expressed. We are already doing classic flow cytometry to identify these cancer cells. This is really a technique to go analyze more number of cells. Usually flow cytometry would capture 10,000 cells. In this case, we're going to look up to 10 million cells. And as you're showing in the diagram here, we're really trying to understand if we look under the surface of the water, and where that cutoff is where all of the blood tests start to normalize. Are we seeing just an ice cube or still a big iceberg underneath? So flow cytometry is sort of already available at a lot of institutions. Being able to set up these extra colors to look more definitively for the cancer cells has actually been kind of gradually getting adopted at academic centers all around the country. A different technology is evaluating the genetic makeup that define the cancer cells, such as that if we know the signature of the cancer cells at the onset, when there are a lot of them, we'll be able to, in this setting, look for that signature when the cancer cells are not easily visible. So that technology is in fact already approved, and it's commercialized under a company name called Adaptive, and the technology is called clonoSEQ. So that technology would require sending sample to the third entity, and then you get the results back. The key difference, I think, is you have to know the signature of the cancer cell. So you're going to need analysis of both the sample at the time of diagnosis and also at the time that the MRD testing is being done. Love both techniques. I think ultimately the key thing is going to be if we were going to do the MRD testing by flow, then the assay itself needs to be sensitive enough. And there's been a survey across academic institutions that was done, I believe, 4 or 5 years ago now, to evaluate how different or similar the analyses and the setup were among different institutions, and there was still quite a bit of heterogeneity. Ultimately, being able to say that the sensitivity cutoff should actually be 10 to the minus 5 to 10 to the minus 6. Anything less than that is probably a subpar MRD flow. But the clonoSEQ, it's already standardized. It is 10 to the minus 5. I have used both because I have MRD flow in my institution that is a 10 to minus 6. we use that more because it is so readily available without us needing to ship out the samples. Sometimes when you ship out the samples, you get the sort of, we cannot analyze this because there's not enough of the genetic material for analysis. So that has actually been sort of a negative experience for some of these patients who are looking forward to their report because they have gone through a bone marrow biopsy just for it. And then sort of the data is not evaluable. So we've faced that sometimes.
So I guess it has to be done on the blood the bone marrow, as you said at the moment, and it is more sensitive. I think the pathologists, they're looking at 100 cells and they can count, how many of 100 cells. Here you're saying 10 to minus 5 minus 6, meaning 1 in 100,000 or 1 in a million level of resolution. And both these technologies obviously have their pros and cons, as you said. So I think that in the future, hopefully we will be able to maybe do more sensitive assays in the blood as well. What is your take on that?
I couldn't wait because I think the technology is already being developed, and it's truly the matter of hopefully ability to eventually confirm that it is a reasonable replacement for the bone marrow assay. So I think the correlation is going to be key. I think the limitation of the MRD testing, whether we're doing flow or we're doing the genetic testing, is as you said, we need to do a bone marrow evaluation. That's not always an easy procedure for a lot of patients. And it also doesn't allow very frequent assessment. Many patients will say, well, I can get my M protein analyzed monthly. But for the bone marrow, I mean, anything that's that's more than once a year is a tall order. Particularly now, we're telling people that not only we like to see a really good remission with MRD negative state, but we also want to be sure they're sustained. Like, what does it really mean? How frequent and how long is considered sustained is up for debate. So I think if we can do simple blood test to hopefully replace some of this bone marrow testing, or even to supplement the bone marrow testing, it would be incredible.
So obviously, we've talked about the two methods of assessment. So obviously, people want to know, what does it mean? When you get an MRD assay, first of all, as far as prognosis goes, what do you know? What can you tell us about its ability to prognosticate?
So, of course, now MRD has been incorporated into a whole lot of clinical trials for myeloma now and has proven itself to correlate with progression-free survival or overall survival. Sort of automatically, when I tell my patients, I'd say, if you have weeds in the garden and you can actually get to the very, very small remaining weeds, it's sort of logical to think that the garden that has a lower number of weeds probably would be the garden that has a much better likelihood of being okay for a long time. Now, that is a data as a group, right? So MRD testing has proven itself to be beneficial to help categorizing treatment efficacy. And I think also sort of indirectly suggesting the sensitivity of that kind of weeds, the kind of cancer, to the choice of treatment that's being delivered. So that is the prognostication. It does have predictive value in that if patients get to complete remission and also MRD negative state, they tend to actually also enjoy a longer time that the disease is potentially going to be quiet. But I think there is a caveat in that it's a one snapshot look. Just like looking at the garden, it's hard to know when you get to that low level of weeds. Some of those weeds may blow right back, and in some garden, those weeds may actually stay still. So I think this is why we were talking about, well, we need to look at more than one time point. So I think the value of MRD also needs to take into consideration of the longevity of that MRD. I think in the myeloma world, we got burned a time or two, particularly in the high-risk population, because this is a group of patients that tend to have shorter progression-free survival. And even if they can show themselves to convert to this MRD negative state, it's sort of, you can't just throw a party yet. In fact, they can convert to MRD positivity, and it's a rate of conversion that we have learned recently on a particular clinical trial that was using patients' MRD status to guide when to stop therapy. And I think that might be okay for some of the standard risk patients, but maybe less so for the high risk population. I think another thing also is, I'm sure you and I both have patients who don't even achieve complete remission. They still have M protein detected. We don't even talk MRD. And yet there are just some of those patients that they continue to just hang on to that low level disease, and they don't necessarily progress. I think it's true for MRD too. So because MRD positivity, that doesn't change over time, is probably not going to be the end of the world in some of these patients. And I think the next phase of technology, hopefully, will not just say MRD positive or negative, but will also allow us to understand what's left behind. Because we learned that some of these patients will have a clone that is sort of slow progressing, more kind of stagnant, and they don't necessarily grow. They're just kind of living there, hanging out in the bone marrow. I think before we're actually using this MRD term, many of these patients were kind of coined. They're reversing their residual disease is there, like monoclonal gammopathy type clone. And while they're not eradicated, they don't necessarily grow back. So I'm actually more excited about not only able to do MRD testing in the blood, but also hopefully being able to do cell-free DNA type blood analyses to understand the genetic signature of the remaining cancer cells. Because I think if we're able to separate the MRD positive people from having sort of the stagnant clone, we could just leave them be, comparing to the remaining clones that are actually ready to attack again. And those are going to be the people that we really want to spend extra effort to not only get those positive MRD testing to become negative, but also keep them there. But I'm excited about the technology as a whole. We've come a long, long way.
So I guess to summarize what you said, that it is MRD negative patients on the whole do better than the MRD positive patients. But if you're MRD positive, you shouldn't lose hope, because there are certain groups of patients that, despite being MRD positive, their genetics is such that the disease still will remain in control for long periods of time. So that is very, very insightful. Now, as far as the employment of MRD goes, where do you use it in your practice? Is this something that you do in the context of clinical trials, or are you using it to guide decision-making in any way? Prognosis, yes, it tells you if you're going to, on the whole, for most people, progress quicker than others. But the value of most tests is if it tells you what you can do with that information and make changes. You sort of hinted at maybe if you are sustained MRD negative, which you said, is still to be defined, 6 months, 1 month, 6 months or 1 year of MRD negativity, that maybe you can stop certain maintenance therapies, or perhaps some of these newer fancy drugs like bispecifics that in long-term use cause infections. So that's one use case that you have said that could be, if validated in the future, be where you could use it. But where are you using it today? Are you using it in decision making?
Yeah, but I mean, I think the key point is it is with acceptance of the lack of confirmation. So certainly have patients who I think have actually, particularly maintenance therapy. There's a concern about using maintenance therapy post-transplant, increased risk of secondary malignancy, but also cost and ongoing side effects, which, while may be manageable, it's not like not taking anything. So I've actually used MRD testing to guide when or to provide reassurance that some patients with standard risk disease who've been on maintenance therapy for a few years with consistent MRD negative state, I mean, they're projected to do extraordinarily well. So those patients, I have been somewhat more comfortable using that data to suggest that maybe we have actually done enough to kind of get to that sweet place where maybe stepping away for a little bit with ongoing monitoring of the MRD testing would be an acceptable thing to do. Now, of course, another place now that has actually become more frequently discussed, I think, is in the setting of excellent induction therapy, where so many are already MRD negative even before they proceed to consolidation for stem cell transplant. And that has actually been, I think, in a way, based on phase 3 study that's sort of showing that maybe that's a group that would do extraordinarily well already anyway. I have actually had more patients using their MRD state after good induction regimens to decide to defer the transplant and maybe collecting the stem cells and get on some form of maintenance therapy and sort of more or less kicking the can of transplant down the road. Whether this is going to be utilized more frequently over time and proven itself to be the right thing to do, I think that remains to be tested. But of course, I think your point about looking at MRD as a group and how do we use that information to help the one person in front of us, I think that's key. Who is that patient's twin in the bigger group? I'm having a hard time picking them apart, right? Because there are people who are MRD positive who do really well, and there are also people who are MRD negatives that don't do as well. And I think that risk for that person in front of us is difficult to predict. So in folks who decide to use their MRD data to guide their management, I would warn them that we should plan on also having a chance to repeat that MRD analysis. I think the question that you asked, so is there a situation though that the residual MRD would make us think about modifying treatment? I think that for me is specifically applicable for young patients with high-risk disease. I think this is such a group that we need to do better. The depth of remission and the sustained remission mean so much more, because if the disease were to come back, it is difficult to settle them back. And I think statistically speaking, second remission is always going to be usually shorter than first and so on. So I think in those patients, if they don't achieve MRD negativity, I tend to actually hold on to maintenance therapy or even consider consolidation. And I couldn't help but wonder whether some of ongoing clinical trials, particularly bringing immunotherapy into that space, is going to actually help good number of these patients. Time will tell.
So you pointed out 3 use case scenarios for patients for, it's not routine, but if patients are having side effects or they want to stop and you're on the not sure whether you should stop or not, that MRD may help guide decision-making, though we don't have data from prospective trials to, at the moment, to conclusively support that. The second is for patients who are going to go to transplant but have already had a great response and are maybe even MRD negative before transplant, whether you can delay transplant till time of first progression or later. And the third is for high-risk patients who have either had a transplant or other therapies. If they're not MRD negative, you're inclined to see if you could actually give them more treatment, either the same or something else, to deepen their response, to keep them in their first remission as long as possible, because once you break through first remission, then subsequent remissions are often shorter. So the fourth scenario I just want to ask you about is, what about the scenario where a patient is MRD negative and is being monitored with serial bone marrows and suddenly becomes MRD positive? Do you think that is a situation where you would do anything different?
That's the trickiest one. for most of those folks who were already off maintenance therapy, for example, I think that's the point to discuss about, do we go back to the maintenance therapy? I usually like to confirm that MRD positivity, because oftentimes it's really the negative and positive makes it feel like we're either black or white. In real life, it's a continuum of numbers. So to be sure that we're not being overly confident in the positive, how positive. So oftentimes in those folks who are just merely increasing by a log, so usually that means sort of less than tenfold, for example, I probably would want to repeat MRD testing. And if it's positive again, particularly if it's increasing further, I think now we have 2 data points. It just brings me back to, you know, when we see people's M protein kind of blip from like 0.3 to 0.5, everyone's saying, oh my gosh, it is more than 50% increase, but still it's within that potential margin of error. So, that's usually when I might suggest to patients, you know, maybe that's the time that we would start to, if we haven't done this bone marrow so frequently, if we're on the every other year or whatnot, if we're really monitoring that change in the MRD and we wanted to use that information to trigger something, perhaps we would do that testing a bit more frequently. And that tends to be kind of a choice that I go in with more proactive plan for young patients with high-risk disease. I think for other patients who are with standard risk disease, oftentimes MRD conversion, they're still in complete remission. It is extraordinarily difficult to convince someone who lives a very good drug-free life to come back to be on treatment again, when each and every month I will not be able to tell them whether I have killed any cancer cells, because unless I repeat the MRD testing, I don't know. So I think there are also some patients who, after the first few years of MRD testing, I think decide that, you know what, it is okay to actually cut back on the frequency, not quite what we do on clinical trial, but kind of take a practical approach to it. I'll tell you too, there's a group of patients that I will not worry about MRD, and that's actually older, more frail patients. I'm unsure that this is a necessary thing to do. I mean, of course, in clinical trial, we do them. MRD negativity is prognosticative in the older population too. But I think this is actually where patients get to tell me what's exactly their goal. If their goal is to get to that place where they can enjoy the quality of life without needing to be on something all the time, complete remission is also prognosticative. And if they get there, I don't worry about the MRD testing and yearly MRD testing. I think this is mostly for 75 and above for sure. I'm not sure whether I'm doing the right thing, but I think if the data is not going to guide anything and it's outside clinical trial, I would save them the headache and the anxiety, and I don't do them.
So most of these scenarios that you painted, whether it be to go to transplant or not, to after transplant deepen therapy, to follow to see if you're getting out of a MRD negative state, or to stop maintenance therapy, are pertinent to the frontline treatment of myeloma. Do you see any utility on MRD testing in relapse refractory disease, and also with the newer drugs, the CAR Ts and the bispecifics? Is that an area that where you are utilizing MRD in any manner?
So I start to incorporate MRD testing into those later lines as well, because I think now that treatments get so much better, second line is almost behaving like first line. I mean, we have seen the first line data that gives a PFS that's really extraordinary. It would exceed the PFS that we've had for frontline therapy a decade ago. So it started to incorporate that as well, because I think that's another place yet. Majority of the relapse studies will give treatment until progression, and that can be a very long time, particularly now that we're actually also having really good salvage type regimens. And I think when I like it when you brought up how about the newer therapy, particularly the bispecific antibodies. Well, even in the setting where other things fail, the extraordinary progression-free survival with these new technologies, giving us a pause that we could overtreat a lot of patients. And I think the cumulative toxicity at a certain point become sort of a negative return. So I would probably incorporate the, if patients are already getting complete remission, particularly MRD negative patients should have an ability to be able to stop therapy. And I'll say that even very good partial remission oftentimes can stay quiet for a long time too. So if it really becomes a problem about opportunistic infection, I think maybe mimicking what our lymphoma colleagues have shown with a bispecific antibody, at least that fixed duration is a possibility. It's really probably where I like to see myeloma therapy evolve to. Because we're holding on to treatment for so long, and it becomes sort of we're going to continue until all else fail. I like to think that a drug-free therapy is important too.
Yeah, I think the paradigm of treatment-free interval was what we used to follow in years past, and now then treatments became more tolerable, but again, they do still have side effects, and we started treating everybody to progression as long as they tolerated it. But the pendulum may be swinging back that perhaps for some people, either maintenance therapy, bispecifics, or other treatments as well, may be worth abbreviating, especially in the MRD negative or the sustained MRD negative subset. So I think that this is obviously an area that is very open to controversy. And as we said, there's no consensus around the use of MRD. So having these different viewpoints is very important. I really want to thank you very much for taking the time to tackle such a difficult topic. And I hope that I can count on you to come back and talk to us about yet more topics in the future.
Thank you so much. Thank you for the opportunity. And really, thank you for supporting our patients through this education opportunity.
Thank you very much. I appreciate it.